All right. So this is me. I also go by Dr. J, and Steve Jenkusky. And I'm a psychiatrist, coincidentally, which actually isn't a bad thing to have on the medical board. And I'll get into that in a little bit later on. But I've been in New Mexico since 1990, attended medical school at Southern Illinois University and trained at UNM and worked many years at the Psych Center at UNM, was on the faculty there, trained a lot of residents. And then for the past 10 years or so, I was with Presbyterian and recently also worked with their health plan. But on top of that, and now I'm sort of semi-retired, I've left that job and I'm just doing some part-time work and working with the board. I was appointed to the medical board in 2009 by Governor Richardson, interestingly, because there was thought to be a need to have a psychiatrist on the board, because we do work with impaired physicians and providers with behavioral issues. So it was thought to be very helpful. So I was sort of a non-political appointee. I was actually appointed for my skills. And so I've been on the board and reappointed several times and continue to serve. I am no longer the chairman. I was a chairman for a number of years. I've moved into the secretary position, mostly because that is allowed to be paid. So I'm sort of acting as a medical director. So my time with the board has actually expanded and I'm working much more closely with the staff. So let me give you a little background. So many professions in the United States are licensed, as you know, anywhere from cosmetologists to, physicians have to get licenses. And the New Mexico Medical Board is empowered through something called the New Mexico Medical Practice Act that's been around since the 70s, and that created the board and gave it the authority to license physicians. Our job is to, make sure that medicine is practiced by folks that have the right background, that we certify their education. We make sure they have not had sort of legal problems in the past. We have a staff of about 16 people that handle these licenses, and we have a board that's made of 11 individuals. It was 9. We just added 2 more because we've merged with the osteopathic physicians. So we license medical doctors, MDs, or allopathic physicians. And we just added, they had a separate board, but we've merged with DOs, osteopathic physicians, which I don't know, hopefully most of you are familiar with that. They are essentially trained just like MDs and with some extra training around manipulation, kind of like what chiropractors do. But they basically do all the same things that we do. So we're pretty much interchangeable. So it made sense that our board was merged with theirs. So 2 DOs, as they're called, have been added to the board. We have, of those 11 board members, 2 are civilians, so they're public members, and they are usually folks that are not attached to medicine in any way. We have a woman now who worked with the Department of Aging, and I think she works for Molina now, the insurance company, which is kind of medical. But her name is Buffy Saavedra, which she's the daughter of, I guess, someone who was a pretty well-known legislator at one time. Our other public seat is open. So if anyone's interested, contact the governor's office. It's been vacant for some time now. We really would like to see an interested civilian there. We also regulate physician assistants. So we have 1 spot on the board for physician assistants. So 2 DOs, 1 PA, 2 civilians, and the remainder are all MDs. We meet for a fairly long meeting every 3 months, and then we have an interim meeting in between that. That's usually shorter. Actually, we're having an interim meeting tomorrow where we're going to be going over some regulations, updating our regulations. So as I said, we are authorized by this Medical Practice Act. There are a number of other acts that we follow. One is an Impaired Physicians Act. There's a Pain Relief Act, which involves the regulation of opioids. And I can get into that as much as you'd like, but we've been pretty active in promulgating regulations around how opiates and pain medicines are prescribed. And we do some disciplinary work around that. We also regulate, besides osteopaths and physician assistants, there's kind of a hodgepodge, which is interesting, of other groups that have been put under the medical board just because of the way the legislature decided they needed to be placed somewhere. So we regulate naturopaths, which is kind of a unique entity. They do manipulations. We just recently started regulating naturopaths. I can't say that. They're kind of like primary care providers, but they also are very oriented around nutrition and wellness. So both of those are fairly rare specialties in the United States, but here we are in New Mexico at the cutting edge. Once again, we regulate anesthesiology assistants. They work mostly in UNM, but other places to help put people to sleep. Sleep technicians and genetic counselors. So there's a little bit of a hodgepodge. We don't regulate, as far as the behavioral health world goes, we don't regulate psychologists or social workers. They have their own board, including the prescribing psychologists. They're under the psychology board, and nurse practitioners. So psychiatric nurse practitioners are under the nursing board. So for better or for worse, if you had an issue with those providers, you'd have to go to their respective boards. But we regulate MDs, DOs, and PAs. Those are the folks that you would be, looking at. What do we do when we issue licenses? So folks pay their money. We are a freestanding division within the government. We're sort of under the governor's office. We're not part of what's called the registration and licensing division. And I hope I'm not getting too weedy here, but that's an entity that, does everything from psychologists to tattoo artists to cosmetologists to builders. We're very lucky that we're not in that group because we have dedicated staff and we are funded through licensing fees. So we're not funded by taxpayer money. It's licensing fees. So we are a self-funded entity. What we do, and I'm sure some of you in the audience, may be licensed in whatever you do for a living, and so you probably understand this. But if you want to practice medicine in New Mexico, you have to submit an application. There's a bunch of stuff you got to put in it. What we do as a board, our staff confirms that you legitimately went to whatever medical school you said you went to. That gets a little tricky for folks that went to school overseas or foreign doctors. That gets a little complicated, but we look at that, confirm that you did the residency that you said you did. And we do background checks. We do fingerprinting. We see if someone's ever been arrested, if there's ever been any legal problems. We make sure you're paying your child support. There's a lot of checks in the boxes here. One thing we don't do, and this is important because we sometimes get complaints about this, and we're really not set up to do that. We really are not set up to confirm that someone's competent in the area of medicine they're going to practice in. And that's because we really can't, get into it that deeply. Now, we do acknowledge, if someone says they're board certified, we do confirm that. And we hope that, in other words, like I'm board certified through the American Board of Psychiatry and Neurology. So that's an external entity separate that says this guy passed all the tests. He's got enough experience that we think he knows how to practice psychiatry. We look at that, but we don't, we can't confirm that up front when someone's licensed. So we can confirm that their credentials are accurate and that they haven't gotten into trouble in their previous life. We do get a fair number of applicants that have gotten into trouble in their prior life. And they can still practice medicine, but we have to kind of vet them a little more closely. Sadly, and this is just an aside, it's remarkable how many doctors get in trouble in big cities and then decide they're going to move to New Mexico for some reason. Maybe we're desperate, and I'll tell you from the medical point of view, we don't consider ourselves desperate. You still have to meet the standard to practice medicine as you would in New York City, in Santa Fe or Albuquerque or Las Cruces. But we do look at docs that have gotten into trouble, either legally or otherwise, and we will investigate. And if we are concerned that there were issues of competency, we will put some extra requirements on those physicians to say you've got to go. There's programs where you can go demonstrate you're competent to practice medicine. Or if you've been out of medicine for more than 2 years, working, raising a family, if you're a mom or something, and you've taken a break more than 2 years, we will ask. So it's not always because there was a problem, but just someone's been away from medicine for a while. So we do a lot of these things. And then, ultimately we issue a license. We renew licenses every so many years. If problems come up for a provider, physician, PA, while they're licensed with us, we have a number of things that they're supposed to let us know. If they get arrested, if they get a DUI, if they lose their privileges in a hospital for some reason, if they get fired for quality reasons, they're supposed to let us know. And the entities that hire them are supposed to let us know, like hospitals, or insurance companies are supposed to let us know. And then we follow up. We will issue what's called an internal complaint, and we'll look at what happened and we'll decide, is this a physician who should keep their license? Is it someone who should be working with stipulations, under certain kind of requirements? Or is it a provider that's gotten into trouble with drugs and alcohol? Because surprise, surprise, we doctors are just as likely to have substance use disorders as anybody else, in the world. And it can affect our ability to practice medicine. So one of the things, and I'm jumping around a little bit here. I mentioned to Tom, I do have a PowerPoint, but I wanted, to make eye contact as best we can on a Zoom meeting. So I'll send that out later for you guys to look at. So I'm jumping around a little bit here just to kind of make this more conversational. The topic of impaired physicians is a whole nother topic would be, maybe of interest at some point, especially to physicians. We try really hard, and I think NAMI folks would appreciate this as much as anyone. We try really hard to follow up on the fact that substance use disorder is a treatable illness. They're all treatable illnesses. And if somebody does the right things, they can get control of it and they can go back to practicing medicine. So we actually have a program called the New Mexico Physicians Health and Wellness Program. It used to be called the Monitored Treatment Program, that works with impaired physicians. And if someone, say, had a DUI, if someone, showed up drunk to work, if someone was found to be, stealing medicines and, opiates and taking them, we, get them assessed by this program. They do a diagnostic profile. They make sure they get into the right kind of treatment, and they then monitor. And by monitoring, I mean, there's random drug screening that's required of these docs, where they may have to go, several times a month. They'll get a call in the morning and say, you got to go give a urine test. So it's pretty close monitoring if they're still working. Sometimes folks have to take some time off from their practice to get things under control. The wonderful thing about that program is that something like 90% of the doctors that go into that program at the end of 5 years are back to practicing medicine. So it works out pretty well. Part of that is because most docs have resources, so they can get the treatment they need and pay for it, and they have a lot to lose. If they lose their license, a lot of these are high earning folks. So that's one of the things we do is we monitor for that. I think I'm going to shift to what the board can do for you all at this point. That's sort of a background of what the board does. So very basically, the first thing you can do is, if you want to know more about a DO, an MD, or PA that perhaps you're going to see, or a family's member is going to see, you don't necessarily have to do this. But if you want a little bit of background information, you can go to our website, and we have a doctor lookup link. And you can click on that link and put in the doctor's name, and it'll say, when they graduated. It sometimes will say what school they went to. It'll tell you if they have a license in New Mexico, and when they got the license and when it expires. And then at the bottom, probably should be flagged better than this. It'll say a button that says public actions. And if it says none, that means that we've never taken any action on this provider. They're not stipulated, they're not being monitored for anything. If it says yes, and you click on that button, you can find information, and it's public information, as to whether or not this provider has had issues with us, and where things stand, as far as, did they complete what they were supposed to do, and, they're back, or are they, being stipulated to being monitored for drug use, or, proper prescribing, things like that. The other place where, let me talk about complaints, because that's the other big thing that we do. So you can look up docs. We don't help people find doctors, unfortunately. We can tell you if someone's out there. We really don't have the capacity to help connect people with doctors, but you can look somebody up and see, if they're properly licensed. What we do is we will look into complaints about providers, about doctors or PAs. And how that works is, if you suspect that a provider is a danger to the public in some way, they seem impaired, they're not practicing, safely, you can make a complaint. And I'll talk a little bit about what the different types of complaints are in a second here. But first, when you go into our website, if you want to make a complaint, again, there's a button to the right that says complaints, and there's an FAQ on how to submit a complaint. And there's a button there where you can either download a form to fill out, you can do an online complaint, or you can call the board and actually talk to somebody and issue it. Complaints can be anonymous, although if you're going to do an anonymous complaint, there has to be enough information there for the board to do an investigation. The types of things that we investigate, and I'm going to look at my list here because it's pretty extensive. Number one, injudicious prescribing. If you think someone, and it's just a matter of public record, there were 2 psychiatrists in Albuquerque who we pulled their licenses over the past 10 years that I've been on the board for injudicious prescribing, mostly because they were giving everybody benzos and stimulants, and so eventually it came to our attention, and we investigated and, had them assessed and found that they really were practicing in a dangerous manner. So we do look closely at how controlled substances are prescribed. Everybody focuses on opiates. I tried to point out that benzodiazepines like Xanax and Valium, Klonopin can be pretty dangerous too, especially when combined with alcohol, opiates, and other drugs. We have rules around how these drugs are to be prescribed. Urine drug testing. There's something called a prescription monitoring program that's supposed to be checked to make sure people aren't getting the controlled substances from more than one provider. So that's one area if you're worried about injudicious prescribing. There's medical records issues. People say, I can't get my records. We have rules around that. Sexual boundaries. Every so often we have someone who, gets into trouble with one of their patients. Excessive personal use of drugs, like I said, drug addiction, fraud, gross negligence, issues in other states. If someone gets in trouble in another state and they have a license with us, we have to look into that. Incompetence, practicing without a license, prescribing to family or folks without a chart, without a proper doctor-patient relationship. We do mental health and physical health monitoring, patient abandonment. If someone just drops a patient without doing an orderly transfer of care, that's something we will look into that. Failure to supervise. PAs are supposed to have a supervising physician, if the PA is not being properly supervised. So those are examples of the types of things we would want to look at and we would want to investigate. We have a team of 5 investigators that will request records and then put together a case that will then, we have subcommittees of the board, the various doctors, and we will look at the complaint and we will then make a recommendation as to what should be done. And there's a wide array of things we can do, either nothing, we find there's nothing to the complaint. We can issue a reprimand, a fine. We can require folks to go for competency assessment, for substance use or physical assessment if we think there's impairment. We rarely will suspend a license, like just say you got to stop practicing. We probably do that maybe once or twice a year, and it's usually pretty serious. Like we think there's like sexual abuse, or we have a finding of significant impairment. We had a doctor a number of years ago that the staff sent us a complaint that he wasn't doing very well. So we had him go for psychological testing, and the test came back and said he was dementing. He had moderate dementia, and somehow the staff was keeping him going, so that was, as soon as we heard that, we had an emergency meeting. We, had to have him stop seeing patients. So that, just as an aside, doctors that, and I'm not saying you should watch out for this, but doctors that are solo practitioners, especially non-surgical, seem to get away with not being discovered, whereas docs that work in a big hospital system or are doing things in front of other people, like surgery, are more likely to be discovered. Sadly, my own profession, psychiatry, it's hard to know right away if you've got a bad psychiatrist. I'm going to be perfectly honest. Because it's usually just you and the patient. You don't necessarily know that you're getting incompetent care. But docs that are within bigger systems, it's more likely to be caught. One thing I do want to say, and this is important because we do get these kind of complaints. Unfortunately, we can't really do anything about what I call service complaints. And I learned that term from working with an insurance company, with the Presbyterian Insurance Company, the past few years. So if you find the front desk people are rude, or the doctor was late, by 3 hours seeing you, or wasn't returning a call, that's really not, a violation of the Practice Act. It's probably a violation of, good business or ethical practice. And so those kinds of complaints probably should go to the employer or the insurance company. When I was with Press, we did a lot of service quality complaints. So sometimes you can actually get some satisfaction from going to the insurance company. The medical board is more involved in, some fairly serious stuff. Not that we can't help, like one thing that comes up from now every so often is somebody can't get their records from their doctor. Well, they're supposed to get you their records within 30 days, and whether you can pay or not, they can bill you, but they can't hold your records, more than that. So sometimes letting the board know, a phone call from the board breaks things loose. When something like that happens, we just call the provider and say, look, you got to do this, and then they get released. So let's see. we're cruising along here on time. Maybe I think I've covered quite a bit that I wanted to let you know what the board does. We license, we do set basic standards, we renew, we track our licensees to make sure they're, not getting into too much trouble. One thing I can say, this is separate from a service complaint. Let me add this. Behavioral problems with doctors. We do look into that. If we get complaints that, doctors are treating staff or patients, abusively, rudely or whatever, we will take some action. We may not do a reprimand, but we will send a warning letter, which is not a reportable, it doesn't show up anywhere, but just say, cut it out. You need to be doing this. We'll be watching you, so we will get involved when it's fairly egregious, inappropriate. And we do, it's in the statute. There's a AMA, American Medical Association Code of Ethics that we adhere to. So there are some that handles things like patient abandonment and treating your own family and, being respectful, things like that. Yeah, we do acknowledge that. So anyway, yeah. So our website, you just Google, just put in, New Mexico Medical Board. There is some information in there. There's information on how to look up a doctor and how to put in a complaint. And why don't I stop there and see if you all have questions?
Well, thank you very much, Dr. Jenkusky. Yes, I've got some questions, and then I think we may have some other questions from the audience. When you look at the number of doctors you investigate or find against or restrict in a year, what percentage of that is all doctors practicing in New Mexico? Is it 1/100%, 1/10%, 10%?
Uh-huh. Yep. So I actually have some numbers here that I can look at real quick. So we license around 8,000 doctors, MDs, and around 800 DOs. Now, not all of them practice in New Mexico. There are some, it turns out there's a lot of doctors, for example, in Santa Fe, that, are semi-retired, but happen to have a New Mexico license, but are licensed in other states. So it's around, 9,000 or so licensees. In fiscal year 20, it looks like we took some form of action on about 100. So
1%.
1%. Yeah, not an awful lot. We took some form of action. Now, I would just guess that we probably get 3 to 4 times that number of complaints. So
okay.
we do get several hundreds of complaints. There are a lot of complaints that are, they're just not actionable, or they, they're, like I said, a service complaint or whatever that we wouldn't do anything on. At any one time, we are monitoring around 35 doctors for substance use disorders, which, considering that maybe 5 to 10% of us have a substance use disorder, when you look at the general population, I'm sure we're missing a lot. But these are folks that their disorder came to the attention of others. They either had a DUI or they, got in trouble at work, or there was some behavioral issue,
Excellent.
So, and again, it's not just substance use disorder. We do have some folks that have occasionally a psychiatric disorder, bipolar disorder or something that wasn't properly treated or adequately treated and got them into trouble. We also, I'm sure this won't be a surprise, but narcissism is a big issue with physicians. I don't know if you notice that, but especially male ones, and so sometimes when that crosses into the disorder range, we have behavioral problems, and they are some of the most challenging. They can be very smart, but they think they're smarter and above, everyone else. And it's rare, but we occasionally run into docs like that. The smart ones shape up. They don't want to lose their license, so they make changes, which is good.
Thank you very much.
Yeah.
The next question is, a lot of us get treated by doctors in hospitals, and the care you get is actually a combination of the doctor and the hospital, sometimes more than one doctor's. And for somebody who didn't think they got the right care in a hospital, where do they go? Because you don't regulate hospitals, but you do regulate the doctors in the hospitals, and people don't even always remember which doctor did what to them in a hospital. What do you recommend to somebody who had a bad experience in a hospital and thinks that the state ought to know about that?
So two things, Tom. One is the Department of Health regulates hospitals. So DOH, again, I couldn't tell you who to go into there to contact, but I know they regulate because I've seen them do emergency inspections of hospitals. They'll come in and they will, see what's going on. So, for example, when I've worked on psychiatric units where something unfortunate happened on the unit, somebody was hurt or whatever, and there'd be a visit from the Department of Health, within a matter of days. So I think if it's something where you're worried about the functioning of the care within the hospital, DOH is one place where you can go. The other place, and again, I can just talk for UNM and I'm not officially, because I'm not affiliated with them anymore, but I've worked at UNM and Press, and they believe it or not take quality very seriously. So making a complaint within the hospital system itself, I think is first of all, I think the systems really appreciate it, because they want to do a good job, and they will do very thorough investigations if they get a complaint, of inadequate care. So I would consider both. And I'm glad you pointed that out, that we don't regulate hospitals themselves. So, occasionally we will get a complaint about a particular doctor in an episode of care, and that doctor really had nothing to do with, whatever the unfortunate outcome was. And we said, we can't, we only license and work with individuals.
Excellent. Thank you. We got some questions from our other attendees. Okay. Terry, do you want to start?
Yes. Thank you, Dr. Tom. I just confessed to a little confusion on one of the anecdotes that you shared with us, Doctor. You mentioned the, prescription challenges of a couple of behavioral health providers. And you already told us that you do not regulate that community. So I was curious about the intersection of the medical board, the psychiatric community in a situation like that.
Yeah, I'm sorry, I wasn't clear. We do regulate psychiatrists because they're MDs. So
okay.
Yeah. So
But just not other behavioral health providers.
Right. We do MDs and DOs, and they can be psychiatrists, like myself. And PAs are sometimes doing psychiatric care, physician assistants.
Of course. Yeah.
But we don't do nurse practitioners or psychologists. Yeah.
Okay, that's clarifying.
With their respective boards. Yeah. Sorry, I wasn't clear on that.
No, I appreciate that. Thank you.
Yep.
Craig, you're next.
Thank you. Thank you, Doctor, and thank you for your service on the board. You actually just answered one of my questions, and it related to the New Mexico Physicians Health and Wellness Program. So I take it that it's not available to nurses and nurse practitioners, or is it?
So it turns out, yeah, thanks for the opportunity. I can actually talk a little bit about that, the program. So it's an independent entity. We pay for it. They contract with us. They have an addictionologist, they have a psychiatrist, they have a couple of therapists that do basically case management. They don't deliver care, but they do assessments and they monitor care. They get reports from practice monitors, and they see the results of the urine drug screens that they do. The nurses have their own diversion program. They have their own program within their nursing board. However, our folks handle their urine tests. So the health and wellness program does urine testing for the nurses. Besides doctors, though, they will do the full monitoring service for medical students, dentists, podiatrists, psychologists, pharmacists, and veterinarians. So it isn't just MDs. It's a service that if any licensee board can work with them, contract with them, but the nurses have their own separate program.
I see. Okay, thank you. And a second question also related to the health and wellness program. Can a doctor who's struggling with an addiction or alcoholism or whatever, can they come forward to the program before they've gotten into trouble or gotten caught, if you will, and take advantage of the program without jeopardizing their practice?
Yes, they can. Anyone can essentially volunteer to participate in the program. And as long as that is not in the eyes of the program impacting their work, they can be anonymous. Okay. So we don't know who they are. The health and wellness program, they will tell us how many people they're monitoring anonymously to us.
Oh, I see.
And at any one time, it's around 20 or 25
Great.
That they're working with. And that's great because folks that voluntarily get involved, they can get the urine testing and they can, work with them around getting the right treatment and be monitored. And their record stays confidential and they don't take a hit.
That's great. Thank you.
Yep.
Well, Tom,
Cam?
will go ahead. Yep. Thanks,
Go
Tom.
ahead.
Great. And thank you, Doctor, for your presentation. I was curious to learn a little bit more about patient abandonment and how that applies to specialists that are closing their practices. It's not uncommon for me to hear about people who have worked with specialists who, close a practice, give 2 weeks notice, and then it takes 6 months on waiting lists for that patient to find a new practice. I realize that it must be pretty difficult to enforce patient abandonment when it comes to doctors who are retiring or no longer wish to be doctors because they don't have as much to lose. Right. I'm just curious if that's something that comes up frequently. During COVID, I've seen more doctors close practices than before. I'm just curious, how that plays out.
Yeah,
Thank you.
Yeah, Cameron, this is a tough one, and actually, I've been having discussions with the staff, about what do we do with this, because historically, like I said, we follow the AMA ethics code, and the AMA ethical code around patient discharge or termination or whatever is that you're supposed to give notice. And you're supposed to, as best you can, assist the patient in transferring their care elsewhere. Now, what happens sort of in practice and what the board's expectation has been in the past is that it be a 30-day notice, that it be sent to the patient by a registered letter, so there was some proof that they were informed. I think that's a requirement, in some ways now with email and texting and all that stuff, registered letters, but it is something that was an expectation. And that was sort of thought to be, okay, then we're good, And I'm actually in discussion with some of the staff about getting rid of that 30-day cutoff, because I'm with you. It's very hard to find to transfer care, and patients can't do it often by themselves. They need help. You can't just give them a list or a phone number. Even if you call your insurance company, often they can't find you anybody. So I would really like to see us advocate more for doctors continuing to show some responsibility, and they and their staff actually work to do an orderly transfer of care. Now, I will say one good thing. I don't always have good things to say about insurance companies, but I got to say, working with Presbyterian in the Medicaid program, which is where I was before, we bent over backwards to assist patients to find care. We worked really hard. So that's another option. Again, if you've got a decent insurance company, then you can contact them and they can help out. But it's a problem, and where we would take action is if someone just shut their doors, and patients couldn't get their records, couldn't get their meds. We would probably be looking at that. But our expectation is that at least a month. I would like to see that potentially be longer, and that especially folks that are on life-sustaining medicines, like insulin or antipsychotics or, things that you can't just stop, that the provider and their group makes a really good effort to make sure there is a transfer of care. But the whole COVID thing was a mess. That's another discussion, maybe for another day. This talk that I put together here that I'm going to share with you all was actually for another presentation. But one of the things I talk about at the end is the role of the board under all the changes that are being brought forth by the COVID epidemic. For example, telemedicine. We don't have good regs around telemedicine. And I think there's a lot of good and bad things that may be coming down the line, like internet prescribing, which is probably not a good idea, but also expanding appropriate access to telemedicine. How do we manage that, and what kind of regulations should we have around that?
Great. Thank you. That's very interesting. I think about the telemedicine when it comes to seeing doctors who are in different states by telemedicine and who regulates. But yeah, thank you.
No, I to that point, you're supposed to have a license in the state where the patient is. You're supposed to have a license. So these telemedicine companies, there is some talk of having a federal license. That's good and bad, where you can practice in any state. I think the problem with a federal license is if you have a complaint, who's going to do a better job, tracking down the complaint, the federal government or your state agency, who knows? But we've had to loosen up a lot of the rules around that during COVID. And but at least the way things are structured right now, if you see a doc at MD Anderson or something out of state, if that doctor sees you and you're sitting in New Mexico, they're supposed to have a New Mexico license.
Okay, thank you.
Thank you very much. Great discussion. I've got a few more questions just listening to this. Cam's question about telemedicine, or your mention of telemedicine. One of the other things that's happening is we have all these electronic monitoring devices. They really fall under the category of fitness, but in fact, most of them are monitoring vital signs, just like you get monitored in a hospital, almost everything except blood pressure. And I'm sure it's not long before somebody's watch allows you to monitor blood pressure. At some point, this is all going to feed into a computer somewhere that's going to come back and say you have AFib, and in fact, that's already doing, fibrillation in the heart or other things. How does the medical board's responsibility monitoring medicine get impacted by this whole technology explosion where your doctor may be in your cell phone and it may be made of silicon instead of flesh and blood?
Right. Yeah, Tom, we're thinking about those things. We haven't caught up. Coincidentally, I'm currently in the process of writing proposed regulations around telemedicine for the board to review and digest. And there's different, and you touched on them. There's different categories of electronic medicine delivery, I guess, that we've got to look at. One is pretty straightforward. What we're doing right now, which is telemedicine, synchronous, real time. This kind of delivery of care has been around for like 30 years. Especially in psychiatry, this has been done for a long time. It hasn't always been paid for, so it really hasn't exploded like it has now, because a lot of insurance companies, the federal government said, pay for this, under the pandemic. So this sort of direct care is something that is for a lot of delivery of care is probably legitimate and okay, but there needs to be some regulation to make sure that, if you're working with someone who really needs to be physically examined, like they've got a pain issue or an injury, that's what needs to happen. So there's this, synchronous telemedicine. Then the next step is asynchronous, which is where you go into a website and you type in your symptoms, and that gets shipped off to a provider somewhere, and they look at it, and then they send you something back, either on the internet or, texting or whatever. That's asynchronous care. That's a little questionable, that's, you hear these ads for, erectile dysfunction meds and things like that, just put your information in, they advertise for that on CNBC and some of these stations. That's not legal in New Mexico, by the way. A doctor needs to look at you, like this. But when is that okay? Maybe eventually that for certain types of illnesses, internet, care is okay. The next thing is what you've talked about, this monitoring, which is being done in some settings, where they will have continuous monitoring of vital signs or whatever. Presbyterian, when I worked there, the intensive care unit at the Rust Hospital was being managed by doctors in St. Louis. And they were watching monitors, they were keeping an eye. There were doctors in the hospital too, but the ICU patients were being monitored from sort of a air control tower, in the St. Louis area. So that is really, the technology per se is not regulated by us. Probably should be regulated by somebody like the FDA or something. The FDA. And then the final category is what you said, which is artificial intelligence. And we were actually, as the board, we were approached by a physician 2-3 years ago, pre-COVID, because he had this idea of actually putting together an electronic program, and he had people working with them on it, where you would type in your symptoms and the computer would tell you what you had, how it should be treated, and maybe even recommend medications, which is blatantly illegal right now. But maybe that's coming. There are artificial intelligence programs now that read X-rays better than radiologists do in some cases. So there's a whole brave new world situation that we have here. And right now, the only rule we have in New Mexico is that you, if you're going to do telemedicine, it should be face-to-face, like we're doing here. Mm-hmm. So Tom, you bring up a great question. There the way this is regulated varies tremendously state to state. There are some states where you flat out are not supposed to do telephone care. Now, all doctors do telephone care. If you know your patient, they call you up and you say, oh yeah, you need this, or I'm going to change your medicines. So there's a wide, it's a brave new world. And I think what's happening, it's moving very quickly because of COVID. There are now a lot of big telemedicine companies that are, I think, seeing dollar signs. I mean, they want to provide a legitimate service, maybe, but they're also looking at, making money and taking advantage of this. So that needs to be regulated. I think we need to know what type of care can be delivered in a quality manner by these different modalities. And then the other thing is, what's insurance going to pay for, which is often the bottom line.
Thank you very much. One hopefully last question. One of the things COVID has really revealed and even worsened is the shortage of medical personnel in New Mexico. And I guess I know we've got some emergencies authorizations in place that people can practice here with telemedicine without going through all the licensing. But longer term, I went to get an appointment with my doctor and I had to wait 3 months because there just, wasn't availability, and I'm not unique in that right now. And so my question is, does the medical board have a role or have ideas for how to expand the doctor and DO healthcare population in New Mexico to help us address this?
Yeah, I think from medical board point of view, I don't think there's a lot we can do. We can try to make licensure as easy as possible, which we're doing. And in fact, we're about to spend $1 million on a new computer system that is supposed to make licensing go a little more smoothly and efficiently, we hope. I personally don't see us lowering our standards in any way. I think we still need to have people qualified to practice medicine. I think what New Mexico, frankly, what New Mexico struggles with is, there's a lot of things. The New Mexico economy. I've been in a position to hire docs in prior jobs, and sometimes I couldn't get a doc because there wasn't a job for their spouse, and maybe they did something fairly technical, and there just wasn't anything here in New Mexico. Or, and this sounds terrible, but I had a doc, I did manage to recruit him, but he discovered the first house he put money down on was a prior meth lab. And, and that's embarrassing. And, there's the whole reputation thing, the whole Breaking Bad's kind of moving into our memories. But I think getting people to New Mexico is really a challenge. I'll tell you what got me to New Mexico. And I think this is what we need to move towards. I grew up in New York. I'm from New York City, but did my medical training in Illinois. And I always was fascinated with the Southwest because I had made a trip out here. And for residency, I requested applications from a variety of states around here. New Mexico put a New Mexico tourist guide in with the application. And I looked at it, I go, wow, this place looks pretty cool. I didn't know where New Mexico was, frankly, and neither did my family. They thought I was leaving the country when I came here. And I was like, this is a great place, and I love New Mexico. It is a beautiful place. So I think we've got an advertising problem. I think we have a financial problem. I hate to say that it comes down to money, but the psychiatrists at UNM pumps out like 10 psychiatrists every year. They almost all leave the state. because they can make 50% or double money in other states. And in states like Montana, they're not going to big cities, So I think we have a reimbursement issue here. Docs are coming out with loans, big loans that they have to pay for. And ordinarily psychiatry is not a highly paid loan. So it's multifactorial, Oh, and Tom, and two other things, COVID hits and something like half the doctors in New Mexico are over 55, so we've got this aging curve that's working against us. And I think two things: the electronic medical record in COVID has pushed a lot of older doctors out of practice because they didn't want to deal with the electronic medical record. And now then there's the whole COVID thing. So I don't have to answer your question, I'm not sure what the board can do. We try to make it easy for people to get a license as long as they meet, the quality standards that we have. But I think we've got to work on New Mexico's reputation, reimbursement, the economy. And something like, and also it's a national problem. 20% of people in healthcare have quit during COVID. 20%, not just docs, nurses, techs, the COVID's done a number on this country and healthcare.
Is part of the issue as well just recruiting to poor states like New Mexico? I mean, because you mentioned it's the economy, but it's also just the demographics of our state from an economic standpoint.
Yeah. No, I think we, one thing the state has done is they've opened up some more primary care residency programs in rural areas, like in Gallup and Las Cruces, and Santa Fe has one for primary care and psychiatry too. I think if we can get folks into those programs so they get to know the community, if there's loan forgiveness, opportunities, which there are, and again, some people want to live in rural places like this, so try to, market ourselves better and recruit. Yeah. Yep.
Wonderful. Thank you, Dr. Jenkusky or Dr. J. I really appreciate all of your comments, and this dialogue has just been wonderful.
Great.
That concludes our presentation for tonight.